Um, Hello, everyone. My name's Grant Russell, and I'd like to welcome you to medicsvoices.com, where we talk to the key opinion leaders in health, medicine, and in particular in primary care. Today we're in Australia, and I'm talking to Professor Nick Zwar. Nick's the Executive Dean, Faculty of Health Sciences and Medicine at Bond University on the Gold Coast in sunny Queensland, Australia. He works as a GP and has had a wonderful career as a researcher in primary care and general practice. And Nick and I go back a long way, but maybe that's for another day. Let's start off, Nick, though. So thank you for joining us. And I wonder if we could go right back to the beginning and wonder if you could let us know where this journey started and where'd you grow up and what was your path through school to medicine?
Yeah, thanks, Grant, and thanks for the opportunity. Yeah, we do go back a long way, but not quite that far. So I grew up in Canberra, which is the capital city of Australia, though one of those purpose-built places when Sydney and Melbourne couldn't agree on where the capital could be, they had to go somewhere in between. And when I was growing up in Canberra, there was no medical school. The Australian National University didn't at that stage have a medical school. So people from Canberra had to look elsewhere. I didn't have a lot of sort of medical role models, so I was kind of, my probably the closest understanding of a doctor was our local GP, who was a wonderful man, a wonderful doctor, one of those people who could do everything type GPs. But unlike people I subsequently met in medicine, who a lot of whom had relatives, close relatives who were doctors, I didn't really have that. So I was kind of going to medicine without knowing a lot about it, to be straightforward. But I thought it would have a human aspect as well as a scientific aspect. And I very much enjoyed English and history and those sorts of things. I was probably more an arts focused school student rather than a sciences one, but I had to science as well. And I thought, well, medicine will probably bring those two together. And I think that was broadly right. It does. And so, yeah, so that's how I went into medicine, not knowing much about it really. But went off to the University of Adelaide and started in first year, as you did.
And just for our international viewers, one of the things about Australian or a big chunk of Australian care, and certainly when we were at the same age, you would go straight from school into medicine. So there was a whole lot of 16-year-olds needing to make their decisions about where they were going to be going.
Yeah, I mean, we had a saying, I don't know if you've heard this, instead of going through puberty, I went to medical school. It was very structured and it gave you time to grow up, that 6 year program. So it wasn't all bad from that point of view. And to sort of just looked old enough, just when you became an intern to not be ridiculous. Yeah.
So your internship was in Adelaide?
Yep. Royal Adelaide Hospital. Yep. Yes, and that was as internships still are, I think, challenging, interesting. You put on those days we all wore white coats. You strapped that on the first day or put it on, had your little large beeper in your pocket, your stethoscope, your little pocket guide to examining patients, your notebook, and you thought, this can't be true. Surely they're not giving me these responsibilities. Someone's going to come and say, oh, don't be ridiculous any moment.
Those imposter syndromes start very early, don't they?
Mm.
So Nick, a lot of your colleagues would have gone into speciality training programs, and it was about the time that professional training for general practice was just beginning to get started in Australia. And just wondered why you went down the general practice road.
So I went back to Canberra after intern year and did my GP training from the Australian Capital Territory, which is the name of the area where Canberra is located. That was partly a family decision. My mother wasn't that well, and and I think it was partly because I couldn't make up my mind. I enjoyed various specialties as I rotated through them. I enjoyed pediatrics very much, quite liked medical rotations, but I think generalism. I'm not sure I understood the concept that well then, but I think I thought the breadth was interesting, and I saw friends going into specialties, and with some interest. I thought about psychiatry at one stage, but then I thought, no, I think general practice, and having some experience in general practice, because those days you get a rotation out from the hospital as part of the GP training. And so you had some opportunity to see things as you're still a junior hospital-based doctor from the GP perspective. And that was, eye-opening. And then I think when I went to one of the general practice workshops that was run through the family medicine program, you remember that, I sort of talked to others who were having the same experiences as me and the educators. And it sort of felt, okay, I've sort of found my tribe here.
Mm.
And I can understand that what I'm experiencing and the challenges and the difficulty of adjusting from a 6-week-old baby to an 85-year-old man on multiple medicines to whatever is what everyone's going through. And I think that helped me to realise I wasn't alone in that, finding general practice primary care really not an easy specialty to actually be good at.
And you started in the training program, which was only just getting formulated at that stage in Australia. And but general practice family medicine is the largest, I think, by numbers, medical speciality in Australia. And but you sort of managed to carve out a little piece of that not many people do, and that's sort of academic family medicine. I just wondered if you could just trace that journey that took you from the sort of the keen young GP trainee into someone who's done a PhD, and has had the career that you've had, which we'll talk about a little bit later on. But I'd love to know how those first steps into that different world started.
Yes, well, as you would remember, Grant, where there was opportunities through that general practice training program to be involved in the Trainees Association, it was called at the time, and I think already at that point I realised I wanted to do other things besides being a clinician. I enjoyed being a clinician, but I realised how hard work it is, and how at the end of the day, after a day in clinical practice, you just you are really worn out. You've used your brain, you've interacted a lot, you've had a lot of sometimes emotional, just people with different stages of emotion, or all of those things that we do in general practice every day. And I enjoyed that, but I thought, I don't want to do this all day, every day. I'm not sure I would sustain that for a career. And so when the opportunity came to get involved in doing other things, which it did through the training program, I took that up. And then you might remember Dr. Jill Gordon. She said, I was working in the New South Wales office of the GP training program, and she said, oh, look, I'll help you, fund you to do one subject of a Masters of Public Health. And that was very clever of Jill, because she realised that might rope me in, and it did very effectively. Because I thought, well, I've done one subject, I might as well do the rest of the Masters of Public Health, which turned out to be quite a lot of work. And then it was, oh, why don't you just do a PhD? We've got this project which you could get involved in. So I was conned. That's basically what happened. I was conned into becoming an academic.
Before you knew what was happening.
Yes, yes. But I think once I sort of realised the interest of academia and the teamwork, because that's one of the great things about doing the sort of projects that we do in academic primary care, is you work with a diversity of people from different skills, but you've got a common problem that you're interested in, that you think is worthwhile, you think is important enough to spend time on, that you would think about how you would get funding to do that project, how you would act on it, deliver it, and you hope that it might change policy or practice. So I think that's quite a creative process, and once you start doing it, you you get to like it.
So it sort of goes from that individual problem solving that is,
Mm,
embedded within a general practice day to maybe
mm.
some um, uh, longer term, maybe more complex, but certainly problem solving that requires often getting a whole lot of people working together at the one time.
Yeah, yeah, and people from a range of backgrounds, and I think that's interesting. Yeah, and I think the other thing is that it's as I've already alluded to, it's a great burnout prevention strategy to be involved in academic work. Whether it's research or teaching, is it keeps you thinking about what you're doing and why you're doing it, and it probably helps you feel that you've got some agency into where you're heading, or where the uh, primary care is heading, general practice is heading, that we actually
Mm,
can have influence on where the discipline's going. We aren't being buffeted only. We are sort of we do have agency and salience in that
mm.
journey.
Just reflecting on sort of the Nick Zwar as an individual in Australian primary care, and I was thinking that there'd be a lot of Australian GPs who knew your name,
Mm,
and I'm guessing that more than a few of them knew you as the travel doctor,
mm.
and you'd had a long-running series in one of the medical magazines on a whole series of really interesting travel topics. I wonder if you could say a little bit about that interest in, but I guess it's a bit of a side interest, but it's been a sustaining one in travel medicine.
Yeah, it has been a side interest. I mean, I started to realize I didn't know much about travel medicine when I was working in a general practice in the inner west of Sydney, and it was an area where a lot of travellers, sort of hostels and accommodation for travellers, and so people would come into the practice and ask for advice. And I realised I'd had almost no previous education in travel health, and how you would provide that advice, and how you would know what the right advice should be. And actually, travel medicine was probably just starting as a discipline at that time. There's a Swiss epidemiologist of infectious diseases, a specialist called Robert Steffen, who kind of invented the idea of travel medicine in the 80s. And so, yeah, I started to think about that, to read about it. I wrote to Australian Doctor magazine and said, I think you need a travel medicine column, because it's something that happens a lot in general practice. And they agreed and told me I should write it. Um, so yeah, as you say, I did that. I don't do it so much now. I occasionally get asked to write an article, but I used to write an article about once a month, once every second month for 30 years. I think that's been going on. And then I developed the interest further. I joined the International Society of Travel Medicine. I did the Certificate of Travel Health through the ISTM. I did some research with other colleagues, particularly about vaccine behaviours of Australian travellers. Got that published in the MJA. Yeah, and it went on from there as a very long-term interest. And I got to know the sort of travel medicine community, I guess, and still, I'm now chair of the uh, RACGP, Royal Australian College of General Practitioners Travel Medicine Specific Interest Group. Ironically, we founded that just as the COVID pandemic was hitting,
Brilliant.
and travel stopped, but it's got over 2,000 members, and
Mm,
it is most of the advice that is given to travellers, from medical advice ahead of travel. About 85% of it's from their usual doctor, so their
mm,
GP, or even 90%. And that
mm,
hasn't changed, and that's true across various countries. So I think primary care doctors, or primary care clinicians, because nurses have a role here too, and pharmacists, are the main providers of travel health advice. So, it is an important area, and it's a fun area as well.
mm. Conferences are good, I understand.
Yeah, the conferences are fun. Yeah, they're in various parts of the world.
Yeah.
And yeah, you can see people that you've got to know over quite a few years. Yeah.
Mm. Nick, it would be unfair to have to speak to you about your professional career without reflecting on your work in chronic disease care, particularly you started off, I think, with rational prescribing.
Mm,
But respiratory medicine's been quite a focus and hypertension.
mm.
Um, just with that as a background, I'd be really interested in knowing some of the people that have influenced you and influenced the way that you've seen things and how your career's evolved.
Yeah, well, there's been a whole number of people. I mean, I was fortunate to meet some of the icons of Australian general practice, like Charles Bridges Webb, many years ago, and got some very sage advice from Charles, which was wonderful. I met Neil Carsons, who of course was another of those figures. Leon Pitterman. I mean, the list goes on. And Michael Kidd, who's more a contemporary than of you and I. And so those primary care or general practice academics who had like Charles and Neil Carson had very deep experience of practice, but came later to academia,
Hmm.
and then saw that transition into where people probably more like you and I and went into academia relatively early in our careers or earlier in our careers. Yeah, and respiratory medicine, I think, happened partly because I was just seeing so much of it as a practitioner who was seeing, kids. When you're younger, tend to see families and children, and there was so much asthma. And that was a big part of our practice in the 90s, late 80s into 90s, and it's changed, and for a whole range of reasons I don't fully understand. But also, when I did my elective as a student, I did it in a respiratory medicine service in Edinburgh, and they had all these men mostly with COPD. And I don't know that I'd really understood how a horrible disease COPD is and how common it is until that time.
Hmm.
And then I developed an interest in helping people to stop smoking and worked with Robin Richmond and others at the University of New South Wales on programs to upskill clinicians, primary care clinicians, particularly in smoking cessation advice. And through that, ended up chairing the College of GP Smoking Cessation Guidelines expert advisory group for many, many, many years, and been involved in numerous iterations of the guidelines document. So there's the respiratory medicine and the tobacco control things obviously came together.
Nick, a few years ago, a friend of mine has a medically qualified son-in-law. He was just completing medicine and about to start with his internship, and she got the idea of writing to all of the doctors that she knew and respected and asked them to give some advice for starting off the journey in medicine.
Mm.
I wonder if I could sort of use that as a bit of a background to asking you if you could just what advice would you give to someone who was maybe either just graduated, just graduating, and has sort of got a bit of a feeling for family practice?
Yeah, a range of things. One would be trying to understand generalism as a really important part of how healthcare needs to be provided, because we see this super specialization in our complex health system, and it's very inefficient. And of course, those super specialists get really good at what they do, but there's so much risk of poor communication, so much risk of people falling through the cracks, so much risk of things being focused on which are not necessarily what the patient really cares about. And health system navigation gets more and more difficult. And I think generalism has a lot to offer the health system and sustainability and trying to provide that whole person care and, all the things, that characteristics of primary care. First contact, generalism, coordination, all of those things that Barbara Starfield talked about. And I think that's important to value, and it's not well understood. It's not well understood by the general community. And I think, we need to value it and try to explain it. And that's how important it is. I think the other thing, I suppose broadly, would be, be curious, be interested in your patients, but also look after yourself. That's so important because, we've all had colleagues, and this is not unique to general practice or primary care, but colleagues who've just worn themselves out by trying to do everything for everyone in a system that doesn't always, really reward excellence and reward quality. So I think, we do have to look after ourselves. The other thing, I think a general thing for anyone who's going to medicine is don't believe everything you're told. Because, when I think back to the things I was told at medical school, some of them were completely false. They just made up, Oh, what causes a peptic ulcer? Oh, it's an imbalance between acid and the protective things of the gastric mucosa or the duodenal mucosa. They had no idea. So that was just someone's theory. And it was taught to us as if that was handed
Brought
down,
down from the mouth.
yeah, from high on a tablet,
Yeah.
And it, took a maverick like, Barry Marshall to kind of challenge that. So I think, having skepticism and being willing to think for yourself is I think important. And in these days where evidence is quite available, I think there's an opportunity to be more willing and able to look at the evidence yourself rather than relying on someone's interpretation.
So Nick, you started off in chilly Canberra,
Mm.
and now you've moved up the coast to the Gold Coast, which is for those internationally, it's on a lot of posters for Australia. The Nick was surfing a couple of days ago, as he does most mornings. I just wonder about the future now, Nick. What are your thoughts for the future for yourself in terms of moving ahead?
Right. Well, so I'm in this executive dean role, running a faculty that's got medicine and allied health and biomedical science and some very good niche research groups, including the Institute for Evidence-Based Healthcare, which was founded by Professor Paul Glasio, a very well-known academic GP epidemiologist. So, trying to continue the success of the faculty and the growth. And when I leave this job, handing it over in as really as good state as I can to whoever succeeds me. And I think that succession planning is part of the next, period of time. And I think for me, and having watched Paul go into retirement recently, trying to think, well, what are the things I want to sort of continue to do after I'm maybe not working full time anymore. And I think some research projects, definitely. Continuing to support people that I've worked with over many years, including some of my PhD students who I continue to work with, and it's great to be able to sort of be some way involved in their research success, and see them sort of, develop their own directions and bring in grants and become research leaders. I think that's really gratifying. I think I'll continue to do clinical work. I may well do a bit more teaching than I've got time to do now because I enjoy teaching, but I get very little time to do it. And I think that could keep one connected and, bright young minds and, all of those things which are part of, maintaining engagement and interest as you get a bit older. But yeah, it's not that totally sketched out, but I think do the things you enjoy, and I won't have to do so many of the things I don't find so much fun.
So Nick, look, it has been a wonderful journey, and on behalf of Medics Voices, I want to thank you for sharing it with us. I think you've embraced generalism, you've celebrated curiosity, and most importantly, you've been able to look after yourself and for those who are close to you. So, Nick, it's been really great. I really appreciate the time that you've spent today. Hope you have a good day, and look forward to meeting up soon. Thanks.
Thanks, Grant. All right, thanks.